Yes, sir, we can start the class.
Hi, everyone, and welcome to this session on anatomy. And we are into the last session of thorax. So, initially, we planned for two sessions, but then we have three sessions of thorax. And in today's session, main discussion will be hovering around the lungs, basically, the bronchopulmonary segments, right? And around the esophagus would be on the topic. And also, we will be discussing about the autonomic system, that is, a sympathetic and parasympathetic around the thoracic area. So, welcome all of you. I'm Dr. Ankit, your anatomy faculty in Auricle, and this session is basically for university exams as well as next exams. Why in this area? These are the main topics or main questions that can come from today's session. You can see the trachea, the bronchial tree. Then we can talk of pulmonary circulation as well as bronchial circulation. We can talk of the esophagus regarding the sympathetic, parasympathetic. Also, we'll be dealing with the carina, as you know, where the trachea bifurcates, right and left lungs, pulmonary ligaments. So, yeah, these are all the topics that we are going to discuss today. So, I welcome all of you, and let's start the session. You can use this code below for any discounts on subscriptions. Why to choose Auricle then comes to mind, and here are just a few features of Auricle, and there are many more. Foundational classes go like this, live classes go like this. Then we have express exam modules. We also have one-to-one doubt clearing session, hard copy notes over here, the Q bank, the practical sessions, nearly covering everything over here, right? These are the subscription plans, right from the foundation plan for 3 months. We have advanced learning, complete learning, and ultimate MBBS plan. Here are all the price brackets given over here, and these two things, the hard copy notes and the one-to-one doubt clearing session. These are extra features which you get in the last two plans. So to avail these plans, here you can use this code which is pasted below in the bottom line, Dr. Ankit 20 over here, and you can use it to avail the discounts on the subscription. Okay, fair enough. Let's come to our topic and let's discuss the questions and the theory part over here. Okay. So basically, we will be discussing, as we already have seen, around the lungs and the esophagus over here. Just a second, some other button has been clicked. 1 second, guys. Okay, right. Okay, so it is thorax part 3, and today being the second last day of the year. So before I miss it, guys, the next session will be happening on next year. So happy New Year in advance to all of you who is listening. And let's end this year with a dose of knowledge. Let's end this year so that we have a good beginning to the year 2025. Okay, so yeah, these are the questions what we were discussing right now, just in the previous slides. The trachea, the bronchial tree over here, the long essay can come. The short essay questions can come around the pulmonary circulation, around the esophagus, around the sympathetic, parasympathetic carina, that is the lungs, and right and left lungs, pulmonary ligaments. You can just see all of these questions. Okay, so it's going to be again a sort of intense 1 hour. Quick revision over here. Be with me. Revise your concepts wherever we get a point. We will make it a point that the important topics are not missed, even for your PG exams as well, right? Let's begin. Let's start with the lungs over here. Okay. So lungs, as we all know, a pair of essential organs for respiration situated on either side of the heart. We all know that they are present where inside our thoracic cavity. So they are a part of thoracic cavity. Basic things, we have two lungs, the right lung and a left lung. Okay. Normally right lung is a bit heavy. It has three lobes. It has three lobes, and the left lung will have two lobes. Okay. But see, these are how to write in the exam. That is something that we need to focus. So just to begin with, it starts with very basic things. So 3-4 lines can be done in the basic, because the question on lungs will be minimum of 4 to 5 marks, can go up to 10, 12 marks. So start with the basics. They are a pair of essential organs of respiration situated inside the thoracic cavity on side of the heart. Then each lung is free in its pleural cavity, that you have to discuss, right? Except for hilum pulmonary ligament. This line is actually important. Each lung is free in its pleural cavity. Then you can discuss a line about the whistle pleura and the parietal pleura over here. One more line over here. Lungs are porous and spongy in nature. Okay, they float in water. They crepitate when handled due to air in the alveoli. So if you handle it, if in your dissection hall, if you might have seen, then you must be well aware of what are these mean actually, what is spongy in texture, what is porous, because unless until you handle the lungs, you are not very confident. So I advise you to attend the DH and look for all those organs over here. It's highly elastic and retracts when removed from the thorax. Okay, though in dissection hall, whatever you get are not are actually all mounted. They are not a normal dead body over there. They are all mounted, meaning by the formalin mounted. So every tissue is fixed. But even then, you can understand few things over here. Surface is shiny, smooth, divided by fine dark lines. At birth, lungs are pink. So remember this. Adults becomes dark green color due to deposition of carbonaceous material. Obviously, the bit of pollution is always there, and inhale due to soils, because respiration is something that is continuous. It goes on entire life, right? So color changes. Here we have the lungs, right and left lungs. You don't have to make this entire, but at least try to make the trachea, the bronchi, and then try to show the lungs over here, the right and left lung. In the left lung, always do remember show a cardiac notch and show a lingula over here. So this is very basic. And then as you will see, you can make two oblique fissures and one horizontal fissure. We will see subsequently. Lungs from fetuses, infants, this is an important point. That is also an applied point. From fetuses or stillborn infants who are not alive, who have not respired. So lungs from those, we can say human body miniatures, stillborn babies who have not respired. So those lungs are firm because air has never entered them. They are non-crepitant and do not float in water. So this is, you can say, for a forensic to distinguish between a lung of a stillborn baby, or whether the baby was live or it was a live birth and has been dead after birth, after living for a few minutes or hours. So lungs from a stillborn will be firm. They will not crepitate, and they will not float in water. That is a very important point to remember. And a bit of weight. So you can understand the right lung is a bit heavier than the left lung, around 50 to 100 grams heavier. The reason being the heart is tilted to the left side, so it occupies that space. Simple as that. Now here comes the core anatomy over here regarding the lungs. So remember to write all the points over here. I'm not here to teach you the entire lung, but to tell you what are important points. I'll use a highlighter over here just to highlight them. Each lung is conical in shape. This word should be there. It has an apex. Apex lies upward. It has a base that is lying below, or also known as diaphragmatic surface. Because diaphragm is below. And remember, in heart, I told you where is the apex, where is the base. So it has an apex and a base that you write. Then you have to talk of the surfaces and borders. In surfaces, at least these two names should be very clear: coastal and medial surface, not mediastinal, medial surface. You'll see later on, or let me just try to show you guys. So if you see a lung over here, say suppose the right lung, so whatever the lung is in contact with the ribs, that all that surface will be known as coastal surface. And this, where arrow I'm putting on, this part of the lungs will be the medial surface. Below, guys, this is the base or diaphragmatic surface already discussed, and this is the apex of the lung. The borders, anterior border and the posterior border and the inferior border. So you have three borders over here. And this, let me use a different color over here. This side over here will have the anterior border. A posterior border will be obviously lying posteriorly, and it will be more rounded. Posterior border will be more rounded. Why? Because on the side here the vertebrae. So it actually takes the curvature of the sides of the vertebrae and the ribs. So it becomes rounded. Anterior border is sharp. Why? Because S for sharp and S for sternum pushes it against we can say against the pericardium. Okay, so anterior border is a bit sharp, posterior border is rounded, and inferior border, guys, is over here. This line over here, it goes all around. This becomes the inferior border. So do remember to write this. This is the basic, guys. This is the basic for your theory exam. No matter you know how much of lung, this is the very basic to begin with. Apex shown over here, so you can just go through these 3-4 points. Depends on the amount of number or amount of marks in that particular question, you can write about it. But do remember a basic point over here, which you should not miss, even because that can come as a vibe. Also, that apex, it even lies above the first costal cartilage, and you will notice that even lies above the clavicle, horizontal level of clavicle. It is a bit, you can say around 1 inch at least, 1 to 2 centimeter, less than 1 inch above the horizontal level of clavicle. It lies in the root of neck. It is covered by cervical pleura. We have discussed type of pleura. Okay. And we also discussed the suprapleural of the substance fascia to remember this, guys. Anti-relations of apex, that can come as a separate 1 or 2 number question, or could come as an enumerate question, right? So remember this also. Let me point over here. That can come as an enumerate question. So at least these three things should be very clear. In front of the apex of the lung lies the scalenus anterior muscle. Okay, and it lies between subclavian vein lies anterior to the muscle, and subclavian artery lies posterior to the muscle, as you can see over here. And let me highlight over here so that this artery and vein, this is the scalenus anterior muscle, and this is the apex of lung. Look at their relations. So these are all the anterior relations of apex. So why is this important? But why is this important? Is because understand, if I use another color over here, just a second, right over here. Okay, so this is our what the mandibular sternina. So let us try to make this clavicle over here. So clavicle is going like this. Okay. So if there is a penetrating injury just above the clavicle, so you should know what are all these structures over here that can be damaged while that penetrating wound or the whatever perforating wound is going towards the apex. So you should know all of these anti-relations. Suppose you are doing an emergency surgery, the patient comes with a knife wound over in the root of the neck. You're opening up the root of the neck. You should know what structure should be there. So these are not just for the, it is correct that, okay, you are giving exams, so you have to be, but understand these all have various practical consequences very soon in your life, guys, very soon in your life. So do remember this, keep note of this point. Around the postulation, so that can also come as a question. Again, in surgery, it will help. Behind lies the neck of first rib. So what actually happens is, if I may try to show you over here once again, this is the, say, the sternum, okay, anteriorly, and this is, say, the first rib. And if I ask you that suprasternal notch lies between which which vertebrae, so you remember, okay, yes sir, we remember. Let me change the color over here to a bit orangish. This was, if you remember, T2, and above this was what? This was T1, obviously, right? So if we try to draw a rib now, so first rib will come from here. Okay, so this will be the first rib. Are you getting a point? And imagine this is going as the clavicle over here. Okay, so this is going as the clavicle over here, right? So where is the apex of the lung? Where would be the apex of the lung? Apex of the lung, as we discussed, that it is slightly above also. So imagine this is the apex of the lung. Okay, this is the apex of the lung. What lies in front of the apex of the lung? What lies in front? Then, okay, here we have this subclavian vessels going, artery, and anterior to artery is the vein. Now, what lies behind? Here we are talking about posterior relations. So posterior relations of the apex of the lung are right over there. Here, this is the part. This is where this anterior surface of the neck of first rib, because head and neck of the ribs are attached, or they are very close to the vertebrae. No, so head is over here, the neck over here, then the angle of the rib, then the shaft of the rib, then the rib comes anteriorly and it joins with the costal cartilage, if you remember. So head, the neck, and tubercles of the rib, even the T for tubercles of the rib, they are attached close to the vertebrae, because they form the costovertebral tubercular costotransverse joint. Okay, so anterior surface of the neck of first rib forms a postulation. Do remember this. And these are all the structures. So these are all the structures. They can be asked to you in a question, like in even PG questions, MCQ. What are the anterior relations of the neck of first rib? These are the anterior relations. You have a sympathetic chain, you have a vein, you have an artery, you have a T1 nerve also. Okay, so do remember this. Do remember this. This is a very important part over here. Now, lateral relations, over lateral relations, not much asked, but even then you should know that, okay, there is a muscle and there is a lower trunk of brachial plexus. If I ask you this forms by CAT1, remember? And a small question, injury to the lower trunk of brachial plexus is known as dash palsy, though it is not as common as the other palsy. Which palsy is it? It is our Column case palsy, okay, lower trunk of brachial plexus. Okay, let's move forward. Now, medial relations of apex. What is medial relation? Think about it. This all will come as medial relation. So instead of cramming, guys, I simply urge you guys to look at the diagram and try to this. This is all what? This is all medial relations of the apex of lung. Yes or no? What we have over here, here we can see that we have trachea, you have esophagus, you have nerves going over here, you have thoracic duct going over here. They will all come as a medial relation. So let us see. Yes, obviously these, if you go from start from anterior, you have the veins over here. You can see this is which vein? This is the brachiocephalic vein, right and left side brachiocephalic. This is the artery over here. Okay, they're all also lying medially. They're also lying medially. So we have a vein, we have an artery, we have a trachea, we have nerves over here on the right side. Trachea is a bit tilted on the right side. Esophagus is a bit tilted on the left side. Else we have a vein and artery and thoracic duct also along with esophagus. Okay, do remember that. See, do always remember all of this. You have to again revise later on when we will doing a subject like surgery, even theoretically and practically. So better be prepared, because here at this stage, guys, in your first years, you have ample time to make your concepts very solid. Let me assure you, if your anatomy or if your first year subjects are solid, I repeat my lines, if your first year subjects are basic concepts are very strong, very solid, no one can stop you from gaining very, very good knowledge in your MBBS. And then whatever you want to do, you can easily do. But this first year, in a bit of second year also is very, very important. Okay, so do remember that. Okay, now comes the base or diaphragmatic surface of the lungs. That can also come as a question. Okay, so what is the base? Below we have the base. So just imagine over here, what could be below the right lung? Mainly is the liver. Yes, so mainly it is the liver. Okay, that is below the right lung or the diaphragmatic surface of the right lung. But between liver and the lungs, we have the diaphragm over here. And similarly, on the left side, what will have? The left side also liver. Yes, left side also we will have the liver, although not shown over here. But let me write over here that in left side we have the fundus stomach, fine spleen also. But on the left side we will also have the left lobe of liver also will be there. Because liver is a huge organ, as you will see in the abdomen. That liver, if imagine this is the midline of the body, imagine this is the midline, and this, say, imagine the diaphragm over here. Just imagine over here. So liver, what happens is liver is not only over here, it reaches till here. This is a huge organ, liver, which actually covers up the stomach, which actually covers up the stomach. It's a huge. So liver, you will also find it below the left lung. Now, so why it is important? Because guys, many a times, lot of malignancies, lot of stuff over here goes between the thorax and abdomen. That will go through the diaphragm only. That is between the thorax and the abdomen. So you should know what are the structures going below and above this part of the lungs. Base of the lung relations, an image over here. So you can see the liver over here is going on that side also. It goes a bit more even. Then you have the spleen in the stomach. Fine, you can make this diagram. This can be this easily made. Now we have seen the apex and the base. Now let's come to the two surfaces, 2S over here. The first one was the costal surface. It's very simple. Just go through them. We have discussed them initially also under the pleura. Costal surface will be smooth and convex because it is convex. It is rounded. Okay, adapted to the thoracic wall. Remember that impressions. You will get these impressions. And these ribs, if you remember, I will show you again. Remember 6, 8, 10, and then plus 2, 8, 10, and 12. What was this? This was the lower limit of the lungs at mid-clavicular plane, mid-axillary plane or mid-axillary line, and paravertebral line. And this 8, 10, 12 was the lower level of the parietal pleura. Okay, that is what is written over here. This scapular line is same as your paravertebral. Okay, so remember this knowledge you can apply over here. Here are shown all these mid-axillary planes. This is the mid-axillary plane over here. This is a red line that is going down, and that is showing us the ribs and the lower margin. So you can see this eighth number over here. Let me change the color a bit. This eighth number, so you can see the eighth number over here. This line is for the inferior border of the right lung. So this is number 8. Okay, and this you can see number 10. This is number 10 for the pleura. Number 10 for the pleura. This is mid-axillary. Same. Go to the mid-clavicular. You will get what 6 and 8 over here. This 8 over here and 6 over here in mid-clavicular plane. These basic numbers you should know. Middle surface now. Now the second surface is middle surface. Middle surface, guys, remember we have an anterior part or mediastinal part, and we have a posterior or the vertebral part. This is vertebral part. And here, what is being trying to show to you guys is, can you see this part over here? Yes, this part. This is the mediastinal part, and a lot of relations are asked. We'll see. That comes as a separate question. And this small part over here, this small part over here, green line over, this is the vertebral part. So they both come under the medial surface. So medial surface will have to, you can see this round. So this round will be the posterior border. I told you it is rounded. And this sharp border over here, that is the anterior border. And this is the root or hilum of the lungs, having all those pulmonary vessels and the bronchi, they are coming in and out. Clear? So remember, two surfaces start with the costal over here and then come to the medial. Divide medial into mediastinal and your vertebral. So you can even make a simple flow chart, no? Okay, then surface like this, and you can simply make, okay, surface, you have a costal surface, And then we have a medial surface. And medial make and divide into two again. Then obviously anterior or the mediastinal surface, posterior or the vertebral surface. Okay, then you can just be more creative while writing. Because writing all those theory, if you have less time, you can take the use of these flowcharts and they will be actually be more presentable. Now here comes these questions. They come as a separate questions, even in the form of MCQs or may your vivas or your theory, whatever it is. So mediastinal part of the right lung, what lies on the mediastinal, what are the structures that lie on the mediastinal surface of the right lung? Here, practice even the diagrams. Practice the diagrams. They can come as a labeling and a lot of stuff can come. What all is written over here, brachiocephalic vein, azygos vein, look where the arrows are going. This is for the brachiocephalic vein. And imagine if I use this blue color over here, darker blue, this brachiocephalic vein is coming down, azygos vein comes on, they both will form what? SVC. Why? Because all is on to the right side. So here you will have the right atrium of the heart. So here is the cardiac impression. But SVC going down where? Into the right atrium. So veins are normally related to the right lung. Veins are normally related to the right lung over here. And the arteries, the aorta, the arch of aorta descending thoracic aorta, they all will be related mainly to the left side or left lung. Simple. Then you have the tracheoesophagus going down over here, other group for esophagus, group for IVC, all you can see. Again, here you will see the group for IVC. IVC group. Why? Because IVC also goes where? Into the right atrium. So this part of the lung over here, this part of the lung is actually the right border of the heart over here. This part of the lungs is related to this cardiac impression is basically for the right atrium of the heart, which forms the right border of the heart. So here from the top you are seeing the SVC and below you are seeing the IVC correlated. Understand? Imagine there's a heart over here. Okay, like this. Similarly for the left lung, what will you have? Mainly have this aorta over here, descending aorta. So this is the anterior part, that is the posterior part. Mainly this. Apart from this, obviously there will be brachiocephalic vein, there will be subclavian artery, tracheoesophagus, and other things will be sort of similar over here, right? Esophagus lying and lingula over here. So this is a cardiac notch, this is a lingula. Now, if they ask you, okay, there's a cardiac impression, now which chamber of the heart is actually in touch over here? And imagine left border of the heart, so that will be mainly LV, left ventricle. Okay, so go like this. Here we can talk of the anterior borders now. Anterior borders, lung is thin, occupies the costum. That's, I guess, this is recesses we already have covered, but just go through them. Take a note them down. Right lung, left lung. About these are just 1, 1, 2, 2, 3, 3 points that you have to remember and write over there. Okay, these are the talking about the pleural reflection. So what is the difference actually between right and left? Let me tell you the basic concepts over here. In the left lung, I am putting some arrows. Let me use a black color over here. Okay, look at this arrows. Okay, so there is a shift in the pleural reflection. Why? Because of the heart. So you can see over here, same till the fourth costal cartilage, till over here it is same. And after that, it moves a bit, 1 or 1.5 inch laterally downward to the sixth costal cartilage because of the cardiac notch over here. Simple. That is the only difference. Let's move ahead. Posterior border of the lung is thick and rounded, as we already discussed. Para, because it lies on the side of vertebrae, paravertebral gutter. You have this levels from C7, it goes up till your T10 over here. Okay, and it is related to what? It is related to the heads of the ribs and the symphytum. So remember this 3-4 points. You can elaborate it. Okay, maximum to maximum, they will come as a 1 or 2 number question of this. So just this borders over here, you can elaborate it. Okay, here you are seeing both the lungs, right and left lung, and they're all their borders, which I already told you. Inferior border of the lung, the last border over here is the inferior border. This also we have discussed, and this image, if you guys remember in the previous session, I hope you are following all our sessions, and we discussed this. And these are all 3 different planes: mid-clavicle, mid-axillary, and posterior part over here. So remember these borders. Finally, you have the difference in right lung and short and left lung. This comes as a very, very important. Let me put 3 star marks over here. It is frequently asked, guys. It is frequently asked. Not a very difficult question, but frequently asked. And try to at least 7 or 8 differences you should be clear, so you can write in the exam. It should be at the tip of your tongue. It is shorter, wider. It is more capacious, more capacity over here. Weight is more. We discussed around 50 grams more. It has 3 lobes, 2 fissures. What are 2 fissures? Oblique and horizontal. Here only oblique fissure. There's no cardiac notch. There's no lingula. There's 1 bronchial artery. Here we have 2 bronchial arteries. You'll see later on. Hilum. There are structures over here lying in hilum. Okay. Now lobes and fissures. As we all know, right lung has 3 lobes. So right lung has 3 lobes and 2 fissures. Left lung has 2 lobes and 1 fissure. Okay, make a flowchart, guys. I'm just for the time being a constraint right now. I just go through a bit fast, but you can make a flowchart of this. Lobes will be have fissures. Fissures are lined by visceral pleura. Okay, blah blah. You can clear the right and left lung. Tell over here. Oblique fissure, guys. Oblique fissure is oblique. It is at an angle. It begins from where ends over here. This is the whole entire course of oblique fissure. This also comes as your in your Viva was also very important. In your surface marking question, it comes. In your surface marking also it comes. And forget about all of this. Once you reach your pass, clear your first year and second year, no, you reach the OPDs, the clinical subject, the medicine, and the TB and chest. There it is very, very important. Why? Because whenever you're auscultating a patient, right, a live patient in your OPD, you're auscultating and you hear some different altered breath sounds. Suppose you hear a wheezing or a craps or ronchi, whatever it is. And so what you will write, sir, there are cracks in the right lung. Where in the right lung? Sir, in upper part. What is upper part of right lung? What is lower part? What is middle part? Becomes a bit confusing, no? So then these fissures are actually helping to divide the lungs into lobes. So if you know the basic idea from where to where fissures will lie, then you can clearly write, okay, sir, it is lying in the middle lobe of the right lung between dash and dash costal cartilages, and this much centimeter from the sternum, something like that. You're getting a point? So this gives a clear picture. This gives a clear picture. Where tomorrow, if you ask the patient to go for HRCT or CT scan of the thorax, you can easily correlate. Okay, this is what I discussed. This is what I discovered in my examination. This is what the report is saying. Understand? This is all have important clinical implications later on also. That is why they are. So oblique fissure over here. Just remember that course. It is running actually throughout. From it starts from posterior border, goes to anterior border over here, and it's cutting the lungs in two parts. And that is same for right and left lung. A very minor difference occurs over there. Okay. Okay, now the horizontal fissure, it is present only in which lung? Right lung. It is present, and normally see, it does not mean, because I have myself seen 3, 4 cases, because so many years have passed me here doing the sections, the DH and all, where the left lung has 3 lobes also. It can also be a case. It is not a disease, it is just a variant, it's just an anatomical variant. Left lung can also have 2 fissures having 3 lobes. So slight anatomical variation is possible. It is not something very major thing has happened. These things are very common. Once you do more and more, you see more and more patients, you see more and more cadavers in DH, you realize that anatomical variations are very common. No two body are alike actually. There's always some slight difference over here, even in some branch of an artery or anything. Right, so coming back, so horizontal fissure, here you can see in the right lung, and this is the horizontal fissure, this is the horizontal fissure, and this over here is the entire oblique fissure. This is the superior lobe, this is the middle lobe, and this is the inferior lobe. Now here, let me tell you one interesting point if you are not yet aware. What is that? This is anterior view, right? This is posterior view, okay? Anterior, posterior view. The moment you are auscultating anything on the front of chest, listen to my words very carefully, where you're auscultating in the front, suppose patient is sitting right in front of you, is auscultating the breath sounds. Everywhere from top to bottom, you auscultated. You have, even if you have auscultated throughout the entire part, you have not yet touched the inferior lobe, or you have not yet touched half of the lungs. Half of the lung will be always missed. So for a complete examination, auscultatory examination of the lung sounds, you always have to auscultate the back also, upper back also. Else it will be you can easily miss a finding. Here, a major disease can be there in the inferior lobe and you have missed it. Okay, so this knowledge should be, okay, it's a basic anatomical knowledge. Else, I have seen many people also who miss this basic thing called anatomy also over there. Now, this is one more applied that you can remember and can come as a separate question also about the azygous lobe of the lung or the accessory or supernumerary lobes. Just go through it, guys. It can be a separate question. Upper azygous or the lower azygous lobe can be there. Here we lobes or azygous vein. So these are two different things over here. Just read them. Not a very major difference, but you should know how to write in the exam over here. Now, root of the lung is, remember the medial surface. We are seeing this sort of structure having all these pulmonary vessels. They contain all these structures. Okay, so root of the lung can be question. High level of the root of the lung, all these. So remember diagram over here. This is a 4-star question also for your PG MCQs. Very, very important image-based questions. So practice the diagram over here. Hilum of the both the right and left lung. Because here you'll see the pulmonary vessels and their artery and the bronchus are a bit of different relations over here. Okay, then hilum of the left lung over here. Diagram, guys. Diagram. Can you spot the differences? Here at the top, you are seeing a pulmonary artery, right? And you have a one bronchus over here, and anteriorly and inferiorly lying the pulmonary veins, because they are oxygenated blood, so they are red in color. Pulmonary artery is deoxygenated, though, so they are shown blue in color. But if you look at the right lung, you'll see an epartial bronchus and a hypartial. So there are two bronchus. Not two bronchus, but actually the bronchus divides into two initially. So that is what is seen over here. And one table over here, just I remember this, mainly for your MCQs. Arrangement of structures. Above downwards in the right and left lung, how they are arranged, anterior posterior, how they are arranged. Okay, this is bronchus artery, bronchus vein. So remember this. Okay, this is the table over here. Keep note of it. It will help you guys. Now, just over here, let me just highlight. If you want to, we can remember everything, but the structure anterior to the root of the lung is mainly, remember, phrenic, mainly. Posterior to the root of the lung, remember, vagus nerve. This comes as a separate question. I'm talking about later stages also. So vagus nerve passes behind the root of the lung. Why, sir? And a bit logic if you want to add over here, because it runs along with the esophagus. Esophagus lies behind. Phrenic nerve lies anteriorly. It also will supply the pericardium. Understand? It supplies the pericardium also. It supplies the pleura also. And then it goes down, supplies the diaphragm ultimately. So it lies in front. Remember this. Now coming to the arterial supply over here, where are the arteries that supply? So they are, remember, I guess in one of the session I discussed that lungs have a dual blood supply, and it is this reason that it is very difficult, or the surgeries over the lungs are very complicated. They are very intense. A small nick here and there, and bleeding can easily occur because it has a dual blood supply. One is a pulmonary circulation, one is a bronchial circulation. The pulmonary circulation is basically for air, oxygenation, deoxygenation, right? And this bronchial circulation is basically to supply the oxygenated blood to the connective tissues of the lungs. So you have pulmonary trunk. We all know the branches follow the division of bronchial tree and runs posterior to the bronchi. Bronchial artery here, people or students normally forget this because it is not that much discussed in the classes and the vivas, but very important. The right lung has only one bronchial artery. Remember this difference. Left lung will have two bronchial arteries. It supplies the conducting system. That is, it gives the oxygenated blood. Pulmonary artery is carrying the deoxygenated blood, but bronchial artery is carrying the oxygenated blood. Can you understand the basic difference, guys? This is oxygenated blood, and pulmonary artery is deoxygenated. It is going there to be oxygenated by the air. Bronchial artery is itself oxygenated. It is supplying the lungs. Right lung will have one bronchial artery, left lung will have two bronchial arteries. From where do they come? We'll see in a while, but a bit of the pulmonary veins, we all know. Where do they drain into which chamber of the heart? Obviously, left atrium of the heart. Let's make a small diagram also if you want to. Okay, now pulmonary artery, pulmonary veins are shown. Here comes the bronchial arteries. Now, right lung had one bronchial artery, left lung had two bronchial arteries. Here, look at this. Let me change the color to black over here. This is the aorta. This is the arch of aorta. Okay, and here this is the descending DTS, descending thoracic aorta. Okay, now see what happens is, as the aorta itself lies to the left of midline, though it is quite in the center, but it is a bit tilted to the left side. Therefore, it gives over here directly these two arteries. They are superior, inferior, left. So left had is two bronchial arteries. Now, if you remember our discussion on the intercostal arteries, okay, anterior and posterior intercostal arteries. Again, you can make flowchart in this particular question. In the posterior intercostal arteries, okay, in the posterior intercostal artery, we discussed about upper two and lower 9 spaces, if you remember. Yes or no? And these all were coming from aorta, lower 9, upper two were coming from subclavians. But as aorta is itself in the midline, okay, so it will give the aorta itself is to not midline, left of midline. So this aorta will give both the right and left posterior intercostal arteries, the low 9 spaces. But this right one has to cross midline. Here you can see. So out of these, right posterior intercostal arteries, the third one. Why third? Because first and second are not coming directly from aorta. First and second are coming from subclavian artery. Understand this. The upper two posterior intercostal arteries are coming from subclavian artery. the lower or the third one over here, that is going to the right side, it will give off the right bronchial artery. So right has one. Normally they can ask as a question, it is, okay, right has one, but it is a branch of which artery? Then you are confused, sir, it is branch of which artery? See, it is oxygenated, no. So it has to come from the aorta. The right one is a branch of the right, the third posterior intercostal artery, and left are directly branches from the aorta. They are directly branches from the aorta. They are not from separate from left posterior, not needed, no. Because on left side we itself have aorta. Why to give separate branch? I mean, one branch going to posterior intercostal, then giving of bronchial, no, directly give bronchial artery. Fine. Okay, similarly for the pulmonary veins, we all know, but bronchial veins, remember, where do they drain? So they drain into azygous system. Azygous on the right and hemizygous on the left side. So this is a very important thing which I told you. It can come as a question, and normally most of the students are not prepared for this, but you guys be prepared for it. Okay, here's the bronchial veins just to show you. So simple diagrams you can make. Okay, where do they drain? That we already discussed. Nerve supply, we have the pulmonary plexus over here. Okay, parasympathetic, and this, remember this difference also. Parasympathetic and sympathetic. But sir, why sir? This is very theoretical, very boring. No, it is not boring. I will tell you how. Have you seen cases of asthma or asthma, to be correct? You have to pronounce this word as asthma. Okay, it is not asthma. It's written as ASTHMA, but asthma. So in asthma, what happens is there is bronchoconstriction. What do you give? You give bronchodilators. The drugs over here are actually sympathetic over here. Okay, you have to give beta 2 bronchodilators, sympathomimetic drugs. Similarly, this parasympathetic over here, it is motor to bronchial, so it is bronchoconstrictor. Okay, it is secretomotor to the glands and sensory stretch and cuff reflex. Opposite of this is sympathetic over here, inhibitory to glands and vasomotor. So remember, this is because cold, cough, cold, asthma, a lot of these all drugs are used over there. These all drugs are used over there. So do remember its importance also. Lymphatic drainage, you have superficial and deep plexuses. Just a couple of words, so you can go through it. A bit of applied. I mean, every answer in the anatomy should ideally be ended with at least a couple of applied. Lung agenesis, which I already told you, azygous vein lobes. Okay, medical legal importance is stillborn, and stillborn, what happens? The lungs will sink in water. Liveborn, the lungs will float in water. So this we have discussed in the beginning. Radiology, all this. So at least 2-3 applied, you should be well versed to write it. Okay, this was guys about the lungs. Let us now discuss about the your tree over here, the bronchial tree. So just remember a few things. Start with the trachea. Then there are two principal bronchus, one for the right, one for the left. This is the principal bronchus. Okay, which color? Yellow color. Then right lung has 3 lobes and left lung has 2 lobes. So that will divide this green color over here. Okay, what is this? This is the lower bronchus for the lobes, also known as secondary bronchus. Okay, each lung has 10 bronchopulmonary segments. Bronchopulmonary segments. Left lung has 2 lobes, so there are 2 lower bronchi, and this third one over here is a segmental bronchus. So this third one is segmental bronchus, and these are all segmental bronchus. There are 10 over here. 5 in the upper lobe, 5 in the lower lobe. So these are tertiary. And then they will go divide, and finally, just remember all these terminologies. It is not very difficult. You have a terminal bronchus. Okay, then you have a lobular bronchiole, then you have terminal bronchioles, this terminal bronchus, then terminal bronchiole, then comes the respiratory bronchiole. This is all the respiratory tree names. It should be very clear. Alveolar duct, atrium, alveolar sac, alveolus, and finally you have the pulmonary circulation over here and the diffusion of the gases over here. And it divides how many times? 15 to 20 times. This division of segmental bronchus till your terminal bronchiole. In between, there's a division 15 to 20 times, or more, maybe more than that, 20 times the division over there. Just imagine. Okay, let's move forward. So next question that can come as a short question is a bronchopulmonary segments. It is a portion of the lung, very important. The definition should be in the very first line, should be crystal clear. Portion of the lung supplied by a tertiary or segmental bronchus. So it is 10 on each side. 10 bronchopulmonary segments on the right lung and 10 bronchopulmonary segments on left. They're supplied by tertiary. So how many tertiary bronchi are there? 10 on each side. How many secondary bronchi are there, or how many lower bronchi are there? Remember this. Lower bronchi, 3 on the right, 2 on the left. How many principal broncas? One on the right, one on the left. Okay, got the point. Okay. Now, each is this part is important over here. So I will use a highlighter so that you to highlight few points over here so that you don't miss these points in your revision. It is an independent respiratory unit, each bronchopulmonary segment. So it becomes surgically very important. Each is pyramidal in shape. We'll see an image also, which with the base towards the surface of the lung. It is pyramidal. It is pyramidal in shape like this. Each segment is separated by the adjacent segment by a septa. So there's a septa which separates the segments. Fair enough. Here's the basic anatomy now. See over here. Each segment has its own separate artery. Okay. The pulmonary veins, this is very, very important. Let me make us 2 stars over. The pulmonary veins run in the intersegmental septa. So the septa which we just saw, on those septa, the pulmonary veins run, not the artery. Okay. It is not a bronchovascular segment, but it is a bronchopulmonary segment. More to it. It is a functional unit of lung. So this bronchopulmonary segment is actually functional unit of lung. Bronchus, artery, septa, and a vein. There are 10 bronchopulmonary segments on each lung. Now, sir, okay, but sir, how many bronchopulmonary segments? Now, these diagrams are very important. Now, this one might confuse you. Here is a table showing you on the right and the left side. You have to answer these. So there's a right lung. How many lobes are there? Upper, middle, and lower. 3 lobes. Left lung, upper and lower lobe. Remember these names, guys. These names you have to remember. 10 on the right side, 10 on the left side. Most of them are overlapping. I'm not going to teach the entire BPS over here, but remember the diagrams which you need to know. Either you can make this one or this one. This one might be practice, guys. It is all about practice. I can't comment which will be easy or which will not be easy. If you practice anything sufficient number of times, it becomes easier, obviously. As I always say in diagrams, the labeling is most important. To start with the trachea, or you can make a bit of larynx over here, and then 2 principal bronchi, and then lower, finally tertiary bronchi. So labeling is most important in a question like bronchopulmonary segment, simple as. So you can use this table over here, and you can make the diagrams or this, whatever you feel like. Now this diagram is for your understanding. This is in front of you, anterior view, and this is your lateral views. So here what you normally see is these are the vertebrae. So this is posterior, this is sternum anterior. So blue color over here is representing what? The lower lobe. Blue color, lower lobe. You can see all that are going in the posterior aspect. Okay, so to remember that thing which we discussed earlier. What is the importance of this? Again, in a question of 4-5 marks, you have to write it. But understand all of this importance is highly clinical. Even in your physiotherapies, if you go to TB chest wards or medicine wards, long-term chronic patients, having lung infections not getting cleared up, had a lot of antibiotics, what to do? Physiotherapy is needed, guys. And then the physiotherapist has to know, the chest physiotherapist has to know the basic anatomy of the lungs. Wherever they are applying those vibration and those exercises, they have to drain. So natural posture drainage of infected regions. So investigations will tell you that this segment is basically infected. So by gravity also you can help by tilting the patient here and there. The physiotherapist will help in draining out those infection or pus from that part. Surgical removal very important for many surgeries like for lung carcinomas or even benign cancers. And to understand why infection are, yes. So just to understand that, okay, whenever we aspirate, so a lot of patients come in aspiration from a small child to adult aspiration. When we somehow by mistake what was there to ingest, what was there to swallow, we inhaled it and that went inside our bronchial tree. So that is known as aspiration. And where it's very small, could be very small things. Which segment they can go, that should be when that becomes a bit clear by this knowledge of the bronchopulmonary segments. Okay, septa helps over here just to for surgery, bronchograms, bronchial branch, so bronchoscopy, lobectomy, so all these operations. And there's a picture over here showing a bronchogram over here. Okay, showing us a bronchogram over here, right? Okay, now comes this your part known as sympathetic parasympathetic. This is what which I wanted to take over here. So we are done with we are done with lungs and BPS segments a bit over here. Now this we all know sympathetic parasympathetic. Let me just quickly revise in less than 1 minute, guys. Sympathetic is actually distributed normally in most part of the body to diffusely spread out to a human body. Parasympathetic is very much localized compared to sympathetic. Point number 1. Second point, what does parasympathetic do? It is easier understood by rest and digest. We just write or remember in our head rest and digest. So while we are resting, heart rate is low, everything is cool, chill. Okay. Or when we have eaten our food, we are lying down after a big lunch. We are lying down for a small nap, digestion. Everything is sorted out. That is rest digest. That is parasympathetic function. Opposite of this, fight or flight response, then comes the sympathetic. Fight or flight response, then comes the sympathetic. So in parasympathetic, what will happen is uh, everything is, very cool, calm environment. Peristalsis is happening. Okay, digestion is happening. So digestion means peristalsis is happening. Peristalsis is going on. There's helps in even urination, defecation, all that. It decreases the heart rate. Sympathetic, on the other hand, will do just the opposite. And fight, flight. Suppose imagine someone has to run away, or there's some danger, and you're so much of worried, and there's so much of tension, and just a matter of milliseconds, you have to decide, and you have to run, or you have to fight, or whatever. It can be a drastic situation. In those sort of few spurts of seconds or minutes, the human body should be in the ideal or in the most efficient possible scenario so that they can handle that pressure. What is needed? People should be dilated, so are looking at a danger. Breathing should be clear, so there's bronchodilation. Okay, I told you, in asthma, bronchodilators are those sympathetics. Blood should be rushed. Heart should be pumping more, so that blood is rushed more towards the muscles, that you can even run fast. Okay, in those times, digestion and all that is not needed. No, suppose you are in ultimate danger, you don't need that your food to digest for that particular 5 minutes or not, no matter. So it is not a big deal. So remember this basic part. So sympathetic system goes diffusely throughout the entire body. Now, anatomically, what we also need to understand is that sympathetic comes, all these are nerve related issues. Sympathetic comes from T1 to L2 part of spinal nerve. Starts from there. Parasympathetic comes from some of the cranial nerves and also comes from the sacral nerves. Which cranial nerves? Mainly third, 7, 9, and 10. Sacral nerves S2, 3, and 4. Simple as that. Now let us see some images over here. So parasympathetic part for the head neck, you have the vagus nerve, and they also go to the cardiac plexus. We'll just see. Just be with me. Okay. Anatomical differences between sympathetic and parasympathetic. So sympathetic always will have a long postganglionic. Let me just use a highlighter over here. Sympathetic will have long postganglionic, and parasympathetic will have short postganglionic. Okay. Short means fibrous length. Let us see more. Here is a what is being shown as a sympathetic. So sympathetic, you can see the ganglia lies very close to the spinal cord. Remember T1 to L2. So that's it's preganglionic is small, but the postganglionic fiber, they are long. L I'm writing over here for long. So what was written? Long postganglionic over here. Because their ganglia are very close to the spinal cord. Let us move. Let us see now parasympathetic over here. Its ganglia is away from the spinal cord. Suppose this comes from the sacral part or cranial part. So its postganglionic fibers are short and preganglionic are L for long over here. So it will have a short postganglionic and a long preganglionic, simple as that. Basic anatomy. Basic thing of sympathetic division, but here you can understand a bit more. Sympathetic trunk, it runs from base of skull to the coccygeal vertebrae. Okay. Output was T1 to L2, but actually the whole distribution is to the entire body, so it will run from here to here. Divided into few parts, cervical, thoracic, lumbar. We'll see more. And here's the difference again. These are sort of images that you can actually make. So let me just use this over here. The sympathetic ganglia, you can see it is very close to the spinal cord. And here's the parasympathetic ganglia. You can understand basic difference. Okay. And parasympathetic coming from the cranial part over here and the sacral part over here. So parasympathetic is basically known as having a craniosacral outflow. The parasympathetic part of the human body is said to have a craniosacral outflow. And the sympathetic part is known as thoracolumbar outflow. Thoracolumbar outflow. This is first thing that you should know. These are all the segments, very important, guys. This is showing us T1 to L2. We are discussing now a bit of sympathetic in detail. So T1 to L2. I said it is distributed to the entire body, but then we start to think, but sir, only T1 to L2, how can it go to the entire body? Here is the reason. From the upper fibers of this whole T1 to L2, they will ascend more above and they will supply the head and neck. Okay, they will supply the head and neck. And this T1 to T6, okay, that will also go to the upper limb, upper extremity. Remember, C5 to T1, T1 over here. And this part, T2, T3, T4, T5, T6, they will go to thoracic viscera, heart and lungs. So cardiac plexus, pulmonary plexus comes from here. But then you have the entire abdominal viscera, lower limbs, also pelvic organs, they all go from T5 below in the form of splanchnic nerves that you'll see. So just this T1 to L2, it is distributed to the entire body. Okay, let me just show you some images over here. Just rushing through it. And here, yeah, here you can understand sympathetic division. Those are the theory images part. Not to worry. For understanding, this is T1 to L2. So from here, can you see this green dots over here? Ultimately, from here, the sympathetic arises. But here, this is the chain of the sympathetic ganglia. This is all what sympathetic ganglia. So you can see it will ascend up also from T1 to it will ascend up. It will go and supply the head neck area. Then it will go straight forward to supply the thoracic viscera, even the upper limbs. Then from here, from around T5 over here, you have, let me highlight the splanchnic nerves. What are these? Thoracic splanchnic, creatal lesser. There's a supply what the abdomen structures. Then you have a superior mesenteric ganglia for a lumbar splanchnic nerve. They'll supply the lower part, that is the pelvic area. So ultimately, they start from here only, but then they spread out to the entire body. They spread out to the entire body. Remember this part. Okay. Okay. Just a few examples over here, just for your understanding. I know that because this topic is very basic. This is not something that will come as a separate topic from the lungs per se, but it is a very basic topic from general anatomy. Normally students miss it. Here, just for 2-3 minutes, go through and understand with the elbow diagrams that you can write it. This is a cut section of the spinal cord. Let me change the color to a bit greenish. This is spinal cord over here. Okay. This is your sympathetic, what you can say, the sympathetic chain of ganglia over here. So from the ventral root, look over here, from the ventral root, the sympathetic, this is the preganglionic sympathetic fiber, it will come out and then it will go where into the spine, sympathetic ganglia. This is known as white rami. It is what it is, myelinated. Okay, now let us move a bit from here. From here it will synapse, and here comes the another rami known as gray rami. That is post-ganglionic. This is what happens. It will go over to the entire body to do what? To supply the blood vessel and the erector pili, that is sweat glands. So sweat is everywhere in the skin, so it has to go everywhere. Blood vessels are everywhere, yes. To regulate the blood pressure, also sympathetic system. What happens in hypertension patients who have high blood pressure? We have to decrease the sympathetic output, so that the blood pressure decreases. So drugs are there also doing those activities. Okay, so this is a simple thing, how the sympathetic pathways to periphery over here. So this is a white rami having the preganglionic over here, the relay, and the postganglionic will go. Next stage over here, just a second. Yes. How the sympathetic reaches the head? It will start from T1 to T4 over here. Can you see T1, T4? How will it reach the head? It relays in the cervical ganglia. And then it will go to the areas on the head neck. By what? By the arteries through but it's the artery here. It does not go inside the artery. The nerves will wrap around the artery. Artery is going to the head neck, no? The nerves will wrap around the artery, outside the artery. This is how it goes through the head. How it goes to thoracic organs, we have seen already. Simple, coming out, relaying, supplying heart and lungs. How it goes to the abdominal organs, splanchnic nerves, remember the name, and goes to prevertebral ganglia like celiac ganglia and all, and then goes to the abdominal organs. How it goes to pelvic organs, again you have the splanchnic nerves relaying in the prevertebral ganglia, going to the structures like bladder, pelvic organs. Adrenal medulla, again it will go directly over here from the thoracic splanchnic nerves, it will go directly to the adrenal medulla. From there the epinephrine, norepinephrine, they come out as a postganglionic nerve. Postganglionic nerve. If I ask you an embryology question, adrenal medulla comes from which part? It is derived from where? neural crest cells, if you remember embryology a bit. Okay. Parasympathetic is this, comes from the cranial nerves. You can see the cranial nerves over here, and below you can see the sacral S2, 3, 4 over here. They are craniosacral outflow. Understand the basic difference, right? So this is about the sympathetic and parasympathetic. Now, quick word about this esophagus. It can also come as a 2, 3 number question. So let's see 5 minutes, give 5 minutes to this also quickly. First of all, where does the esophagus lie? If I ask you in this particular diagram of mediastinum, or if you have to start the answer of esophagus, try draw this diagram. In this diagram of mediastinum, where can you draw the esophagus? The esophagus going like this, just behind the heart, and it is coming down and going out, becoming stomach. So it is passing through which mediastinum? Superior and posterior mediastinum. Okay. Esophagus, a muscular tube, fair enough. You have to write this. Narrowest part of the digestive tube at the it lies at the beginning, pharyngoesophageal junction. So that is a separate question in itself. The narrowest part of the digestive tube is pharyngoesophageal junction, where the esophagus starts. Okay, after the vermiform appendix. So firstly, appendix obviously extends. Esophagus extends from pharynx to the stomach. What is the length of esophagus? Any idea, guys? Length of esophagus. It is around say 25 to 30 centimeter. We have a slide of it also. Just a second. Yeah. Length see over here. It is around 25 to 30 centimeter. Okay. Previous slide. Begins where? At the lower border of cricoid cartilage. Remember, it begins at C6. All these are very important if you're looking at a CT scan or MRI scan, guys. Even your esophageal cancers itself are there. There are a lot of investigations being done. You should know where the esophagus actually starts. It starts as C6 vertebrae, ends where around T10 or T11. It pierces the diaphragm at T10. Remember, I8, 10x at 12. 10x is this. And then around T11, it will become the stomach. The length is this, divided into 3 parts: cervical part in the neck, thoracic part, and your abdominal part, a very small part. If we add up, it becomes around 25-26 centimeter. The longest part is the thoracic part behind the heart. It is running where? Behind the heart over here. Okay, and cervical part, why 4 centimeter? Because it started at C6, then at C7, then which vertebrae? C8 or T1? T1. So over here it is around say 3 to 4 centimeter. And why abdomen part only 1.25? Because at T10 it will pierce diaphragm, and at T11 it will become the stomach. So it is matter of just half or one vertebrae, 1 to 1.25 centimeter. Esophagus. Esophageal cancers are very common, guys, and they spread very fast. Okay, so you should know their blood supply also. One is this course we already have seen. So T8, T10, T11, what happens? Just go through it. Course, you have to write it. Curvatures of esophagus anatomically, that is also important. Why? Because in doing a barium swallow study, suppose there is a barium swallowing, you are seeing a esophagus like this, don't get worried. Okay, so the esophagus is tilted to one side. No, it is normally like that only. Okay, so go through it. Curvatures, constrictions must know, guys. The distance, because you have to insert sometimes a tube known as Ryle's tube. A patient who is not able to feed anything, who's not able to eat anything. Okay, how will you give the food? One route is through the Ryle's tube. Okay, the Ryle's tube, you should know how to. That is a practical thing, but it goes through the esophagus only. And here few constrictions are there. There is a no. These are all natural constrictions. There is this cricopharyngeal constriction over here at the beginning. Then there is this what is a bronchoaortic constriction. Okay, bronchoaortic for the bronchus and the aorta. And finally, there is this diaphragmatic constriction below. Okay, this table, do remember this, guys. This you have to make in a question of esophagus. Constriction of esophagus, distance from incisor, because here you have to put the Ryle's tube. So in those tubes, the markings are given. Should know at how many inches, the 6 inch, 9 inch, 11 inch, 15 inch, the constriction will come. So don't forcefully try to enter. You may damage the esophagus. You know, okay, this point has come. Let me go a bit slowly. Normally, it doesn't cause any obstruction, but you should know, because many investigations can be there where that is needed. Okay, so due to which that is written over here. This is very important. Arterial supply comes as a separate question, both in as MCQ in your PG exams also. Why? Because as I told you, esophageal cancers are very common. So cervical part is supplied by this, inferior thyroid artery, thoracic part is supplied by this, and abdominal part of the esophagus supplied by this. Remember there were 3 parts of esophagus, 3 separate arteries. Inferior thyroid artery, if someone asks you it is a branch of which artery? Inferior thyroid artery will be a branch of which artery? Tell them it's a branch of subclavian artery. Okay, subclavian artery branch. Left gastric artery, they're all coming from your celiac trunk. Okay, that is the reason here in the there is one more important applied, that is your hematomasis, vomiting of blood, esophageal varices. We will see. So venous drainage will be the same. Okay, here is the difference. Because here we had the aorta over here. So in this side we will have azygous hemizygous vein. Okay, lymphatic drainage just can go through this in different names. Applied anatomy, guys. Site of constriction important for passing instruments. Doing even esophagoscopy. Okay, there are many things. No, suppose you have to enter the upper part of the intestine into the stomach, doing even ERCP, going into the pancreatic ducts and all. In the case of gallbladder stones, you have to enter through esophagus only. You should know all of this. Barium soil, as I telling you, congenital atresia. So there are a lot of diseases. There can be a lot of diseases. Just for the first year, at least remember 2-3 names so that you can write them in the exam. Carcinoma is very, very common over here. It is carcinoma, the esophagus is said to be more common in countries like Japan and all. Again, that is what we used to learn when we were UG students, because they have a lot of spicy food, a lot of hot food they ingest. Esophageal varices, this is very, very important. So because of the lower end of esophagus has a portosystemic venous anastomosis. Don't worry too much, it will be dealt more in the abdomen part. But understand, if there is a liver failure of a patient, and liver failure patient can come as vomiting of blood. Because the lower end of esophagus, a lot of vessels over here, they might rupture. And the blood over here is the irritant, it will come out as vomit. Vomiting of blood known as hematomasis. Liver failure cases, carcinoma, not carcinoma, but it's cirrhosis of liver. Okay, so it is very important over there also. Okay, thoracic duct, yes, you can just look at this one line of thoracic duct over here. It is 30 to 45 centimeter long. It is the largest lymphatic duct. Okay, it receives lymph from all of this. But normally the esophagus comes as a, so this applied part, guys. Let me just go through again all of this. Just we'll have 1 more minute over here. So esophagus applied, very important. And then it's mainly artery and venous drainage constriction. So these 3-4 points are right from your first year to your PG exams to your surgery, medicine, everywhere it is needed. Understand this part. Okay, then we had the sympathetic, parasympathetic, understand the basic differences. What do they do? Remember to make a table and divide sympathetic, parasympathetic. That is very, very important. Okay, then we had this bronchopulmonary segments. Remember this diagram, this table, and these basic concepts over here, which I already told over. Okay, then we have this bronchial veins and all this lungs, hilum, root, fissures, differences, border surfaces, all of that. Okay, so that I guess we completed the 3-4 topics over here. Make a quick revision of it. Any doubts, let us know. And that's all from my side. I hope you enjoyed as much as I enjoyed teaching you guys. Thank you for your time. Bye bye. Good night. Take care and happy new year also. See you next year. Bye.